So I think it's important to begin everything with what patients want in thinking about palliative care. And I think we have more of an evidence base. And what we understand from patients is they want pain and symptom control. They want to avoid inappropriate prolongation of the dying process. People want to achieve a sense of control, to relieve the burdens on their family, and to strengthen relationships with their loved ones. So that's what they want, and what happens is that about 40% of them end up getting chemotherapy in the last month of life. About half end up going to the emergency department, half get hospitalized. 35% of them do not receive a hospice referral, and when they do, the tendency is for patients to be referred quite late in the disease. The consequences of these problems are there's a pretty high 30-day hospital mortality, with many patients dying in the hospital, which is not what 80 or 90% of patients want, that there's a great deal of suffering, high costs, and many opportunities for meaningful interactions with families, friends, loved ones lost in this process of focusing on medical treatments when medical treatments may have much less to offer. This is a study which is still the best study that I know of about what care in the hospital is like. It's from the support study, 9,000 patients in 5 teaching hospitals, including one in Massachusetts, showing that half of all patients in the last 3 days of life had moderate to severe pain more than 50% of the time. Think about that. That's terrible. Nearly half of all patients received unwanted medical treatments, also terrible, and almost 40% of those who died spent more than 10 days in an ICU, in a coma, or on a ventilator. We don't have evidence that there have been significant changes in these data since the early 1990s when these data were collected. So I think the conclusion there is patients are not getting what they want in terms of relief of suffering, quality time with families, and so on. Now, what do family caregivers of patients want? This is a study of 475 family members about a year or two after bereavement, and they valued having their loved ones' wishes honored, being included in decision processes, receiving support and assistance at home, getting practical help, having their loved ones' personal care needs met, receiving honest information, having 24/7 access to clinical experts, being listened to, having some privacy, and to be remembered and contacted after the patient's death. So what did they get? This is the best and largest study of family perspectives on the quality of care received at the end of their loved one's life. And in the hospital, and I'll focus on that first, 52% reported inadequate help with their emotions, 27% reported poor physician communication, 78% reported lack of contact with the physician. This one blows my mind in a hospital, but at any rate, 20% reported lack of respect, 8% reported inadequate family support, and overall, less than half reported that their loved one received excellent care. This is not, I think, what any of us would define as a stellar report card, especially since hospice shows us how we can do it better. And again, hospice has a ways to go, but overall 71% of family members were satisfied with the care their loved one received in hospice, with better scores on all the above dimensions that we talked about in the hospital. So I think this is sort of in some ways I think very important data in showing that the desirability of helping patients move into hospice as early as possible to help assure that the patient's needs are met and that the family's needs are met. In addition, the literature shows, and this is a study that was done using Dartmouth Health Atlas data and the prior study that was a large national mortality follow-back study, shows that family members of patients who die in high-intensity hospital service areas reported lower qualities of emotional support, shared decision-making, information about what to expect while the patient was dying, and respectful treatment. So the more medical care, the lower the satisfaction in these areas. So that's the bad news, and I'd like to sort of shift now and talk a little bit about how palliative care works. In palliative care, we work as a team. We collaborate with the primary physicians of the patient, whether that be the primary care physician, the oncologist, the cardiologist, the nephrologist, whoever it is, we collaborate with them and with the rest of their clinical team. We try to individualize treatment to meet the patient's goals. We don't have a cookie-cutter approach. We don't say that, well, everybody should die at home or everybody should die in the hospital. We really try to understand what's important to the patient and the family and try to meet those goals. We practice in an interdisciplinary manner. We have physicians, nurses, social workers, chaplains, pharmacists, music therapists, and mental health clinicians on our teams in order to be able to meet the complex needs of patients and families. We try to offer as much continuity as we can within our crazy fragmented healthcare system. And I think our main procedure and our main focus in palliative care is on intensive communication and emotional support. Our goal in working with patients is to help them achieve quality of life through the illness trajectory. We assess and treat physical symptoms and psychological distress, support families, provide spiritual support to patients and their families, help with decision-making and advanced care planning. We try to support patient and family empowerment, communication, hopefulness, and growth even at the end of life. We also provide a linkage of patients and families with community-based resources like hospice and home care, and we provide bereavement support. And as you can see, this is a very kind of comprehensive set of services that are provided by palliative care, but they meet the very intense needs that patients and families experience at the end of life. I think subsumed in this construct is the idea that we can't treat patients in isolation from their families, since so often families are the caregivers and families are suffering along with their loved ones.